Hi folks, welcome to the Preceptor Training video orientation, and thank you for your time that you've been willing to commit to our students in the past and willing to commit to our students in the future. I'm going to try and keep this as brief as possible, but I have a couple areas that I'd like to go over with you briefly. First off, my name is Jim Simonson and I am a paramedic. I am from the Dayton region. I worked with Riverside Fire Department for several years as a firefighter paramedic. I worked for the Dayton Fire Department, later as a supervisor for Dayton Fire Department. I've been teaching at Sinclair Community College as a professor of emergency medical services now for 10 years. And I have quite a bit of experience, about 20 years in EMS in general. And I am going to be your host as we go through several different aspects to get you comfortable with what to do with paramedic students from various agencies. First thing I'd like to clarify, though, is that since I am from Sinclair Community College, this is not a Sinclair-specific video. This video is designed to cover 4 different institutions. They are Clark State, Fortis College, Miami Valley Career Technological Center, and Sinclair Community College. So when you complete this training, you've not completed a training for one agency, you've completed it for all 4 agencies at once. Additionally, we have a quiz that we're asking that you complete. It's a brief quiz of about 10 to 15 questions to show that you've gone through the training process. And when you fill that out, you're going to be listing all the different agencies that you report to. If you work for Dayton Fire Department and Trotwood and Riverside and Kettering and Miami Valley Hospital and Good Samaritan, that's great. Mark all of those boxes and we'll make sure that you're on the roster for each of those institutions, and the EMS coordinators at each of those agencies then know that you've been through this training process. The one thing I did want to clarify, though, is while I was a Dayton paramedic, I would transport patients to Miami Valley Hospital. That doesn't mean that I was on Miami Valley Hospital's roster. Likewise with Good Samaritan, Grandview, I've been to all the major hospitals in the area, Children's Medical Center, Dayton Heart Hospital, St. Elizabeth's back in the old days. So that doesn't mean that I was a member of those agencies. So when you're marking this, only mark the agencies that you have a specific relationship with as an employee-employer relationship. And that can be whether you're volunteer or whether you're as a regular employee, part-time or full-time. So once you've completed that, that will complete your requirements as far as the orientation. What is the purpose of this orientation? Well, the purpose here is that in 2018, all paramedic programs are going to be required to have a national accreditation status. The national accreditation allows the programs to function under the national curriculum. And as I said, it'll be required in 2018, which seems like a long time off, but actually starting back in 2013, in order to offer a national registry certification, which gives portability of our students to go from state to state, in many cases, you had to have gone through this and have to have at least applied for the national accreditation process. So while we've got a little bit of time for the state of Ohio, we're already there with the national registry, and our requirements are that we have to provide a video or some other form of orientation process. It can be in person, it can be video, it can be any other way, that has demonstrated that our preceptors know what's happening for the students' purposes. The purpose of this video is to provide the information that you need in order to demonstrate that competency and give you the information that you need to properly precept our students. The quiz allows us to track who has actually gone through the training. Now, if you're unable to watch the entire video or don't want to watch the entire video, you can use this off of your own personal experience. And you can also refer to, I will be referring multiple times to our Preceptor Training Manual. This is available at all the major facilities, all the hospitals, all the EMS departments, field agencies, and so forth, and has all the basic information that I'm going to cover within this video in this site. If you don't have immediate access to this, you can contact the EMS office at your agency, whichever institution has the most students coming to your area. For example, if you primarily have Fortis students, you can contact Fortis or Clark State or Miami Valley CTC or Sinclair, and we'll be happy to either send you a PDF copy or get you a link to where you can get a hold of one of our Preceptor Training manuals that you can look at on your own. The carrot that we're going to give you, and as a thank you for taking the time to go through this process, is once you've completed the quiz, you're eligible to get 1 hour of continuing education in EMS. Now, in order to complete this, one of the State Board of EMS requirements is that you have to complete a brief course survey. So, while you've just finished doing one online quiz, again, 10 to 15 questions, not an extremely big time commitment on there, we're asking one more short quiz from you, and that short quiz is your course survey. What did you think of the training materials and so forth? And we need to get your name and your email address and some contact information from you so that we can submit your certificate to you. We will typically send those as a PDF certificate that you can print out and send in. While it's EMS board, and I have to give a quick disclaimer, I am not a nursing instructor, nor am I a registered nurse, but I have talked with several nursing instructors and looked at the Ohio website for nursing, and I have basically confirmed that if there's another accrediting agency within the state of Ohio, which would include the Board of EMS, that nurses are able to use certain parts of those continuing ed certificates toward their nursing recertification. And I kind of got the impression from the instructors I've talked to that yes, they can use this hour of generalized continuing ed if you need it. You're welcome to get that certificate. It's listed as EMS continuing education hours, but to my understanding that should work. The disclaimer on there is please make sure you double check that before you put yourself in a nasty audit situation on there. If you have any questions, please contact the agency that your students primarily come from. Again, Clark State, Fortis, Miami Valley CTC, or Sinclair, any of the four of us, contact that primary coordinator at that site and they can help answer any additional questions for you. Okay, well now we need to get into some of the details of exactly what happens while you're precepting students. First off, we have several different certification levels that may be coming to your institution to do clinicals. They are EMTs, or Emergency Medical Technicians, Advanced EMTs, and Paramedics. In the old days we had EMTBs, EMTIs, EMTP. Those terms have actually gone away now. It's EMT, Emergency Medical Technician, is that level that we used to classify as basic. It's just now listed as Emergency Medical Technician. Advanced Emergency Medical Technicians are not really within the scope of this video as they're fairly few and far between. If you run into that, typically they're EMTs that have ability to do some additional skills such as IV access or manual defibrillation, and your best bet is to talk to the student and find out what their specific clinical needs are, confirm it with the EMS department at whatever educational institution if you need additional information. So for an EMT, I'm going to use my notes here to make sure I don't forget big stuff. What are some of the characteristics? All students, regardless of their certification levels, have had a standard precautions statement, which is a health cert from a doctor. They've had their shots, they've had their hepatitis B series, they've had a health screening, they've had the requirements, influenza, and so forth, whatever has been negotiated in the contracts between the educational institution and the EMS agency. They've been trained on professional conduct, which includes but is not limited to HIPAA and privacy concerns, and that's a big deal for us. It's a major concern. The students don't have the right to jump on Facebook and start talking about your patients. They have a dress code. The dress code is specific to the students. They can't come in looking like a slob. Essentially, for an EMT student, since they have a relatively limited clinical experience, just a simple white shirt, dark pants, black pants possibly, dark shoes, and some kind of an identifying badge that indicates which program that they're coming from. It should be a name badge depending on the program. But their shirts may not be a location-specific shirt simply because they're only going for 8 to 16 hours worth of clinical, and we felt it's a little bit unfair to ask them to purchase specific clothing that they'll only wear once. For the paramedic students at all the agencies, they will have a site-specific or an educational institution-specific logo on their shirt. As you can see, I have Sinclair on mine. Others from Fortis or Clark State or from Miami Valley CTC will have comparable logos that are designated on there for the paramedic students. they're going to be doing anywhere from 200 up to 600 hours worth of clinical. So it's not too unfair to ask them to buy a specific shirt to wear while they're at those sites. And once again, they'll be wearing dark pants and comfortable work shoes and a name badge. Typically, the paramedic students will have something more like a photo ID with a logo on there, but that's going to be institution specific on there. Now, laboratory skill requirements. What have these students been checked off on? For all students, they've been checked off on basic patient assessment. They've trained on how to do a patient assessment. For an EMT level student, that's going to be pretty sketchy. You're not going to have great detail as far as exactly all the inner workings of the different disease processes. They know how to do a head-to-toe assessment, how to get vitals, how to look at skin color, temperature, condition, how to listen to lung sounds and take vital signs and so forth. But they're not going to get real detailed, nor are they going to be doing much in the way of critical thinking on those aspects. They do know how to do some lifting and moving, so if you need to shift or adjust a patient, they should be competent in doing so. They know how to use an AED properly, and they have some basic pharmacology. Now, basic level pharmacology here is very basic. It's essentially aspirin, nitro, EpiPen, and a metered dose inhaler. So it's very limited in scope. They don't have great deals of expertise on this. They do not have the knowledge or the ability to start IVs or do intravenous activity. We've had some occasional students who have been through a phlebotomy program in the past and they're wanting to push medications. That's inappropriate for an EMT level student. So make sure that you're aware of which type of student you're dealing with when you're in those situations. At the paramedic level, they also have training in IV or IO access. So they have the ability to start IVs or start an IO in the rare case that's necessary. They can push medications. Now, depending on where they are on their program, they might be fairly comfortable with some standard street medications or standard common medications that are prescribed, but they're not going to be well versed on all medications that are out there. Later paramedic students that are toward the end of their program might have a lot more experience and a lot more knowledge on there. Blood draws, they are familiar with drawing blood, but they might not be completely up to date on how do I invert a purple top versus a red top and so forth. So you might need to go over those aspects with them. As far as drawing the blood, they should be comfortable with that aspect. Advanced airway management, which includes any of the blind insertion airway devices, the King airways, comba tubes, the PTL airways or laryngeal mask airways and all. They've at least been introduced to them. They're probably not highly well versed on there, but all of the paramedic students will have been tested and are competent in endotracheal intubation. So in the rare experience that they get to do an endotracheal intubation in the hospital setting outside of an OR, please, if they can, let them do it. They should be competent in doing so. We've had a couple that have done that recently, and it's been a godsend for us as far as getting people through the skills that they need to get done. The preceptors have the ability to verify what skills a student is capable of performing by looking at the front of their clinical handbook. Each student will carry a handbook with them that has copies of the daily clinical activity log. We'll talk about that a little bit later, and assessment forms. It also has a check sheet at the front that signs off on which skills they're competent in performing. I will let you know that the students are supposed to bring these into labs and get them checked off on a periodic basis, and sometimes they're a little slow about doing that. And if that's the case, you may have some students that say they're available to do a skill and they're not signed off on it. You can absolutely and probably should go by what's written in that textbook, and they might miss out on the opportunity to do a skill, but hopefully it'll remind them that they need to get that signature the next time before they lose that opportunity in the future. The signatures are up in the front of the book, and they'll be updated on a semi-regular basis. If the student explains that they're capable of doing a skill, again, if they're not signed off in the front of the book, it's a little bit of a risk factor, but hopefully the students will be honest and forthright on those areas. Another thing I want to clarify very quickly, even with our paramedic students, there's a slight change. In the past, we would have students that are coming out that are just starting cardiology, but there weren't students in the field for any real length of time without knowing cardiology. Sinclair's program varies from other programs somewhat, but we have the ability for some students to actually go through an entire semester without having any cardiology while they're out in the field. They can still do assessments. They know how to do a chest pain assessment from an EMT basic level standing, but they aren't familiar with ACLS, they aren't familiar with EKG interpretation, let alone 12-lead interpretation, and they certainly don't know all the cardiac meds to push, even on what would seem like a routine code. So just keep that in mind as you're looking at those sheets and determining what skills a student is comfortable with. Not all students coming out are going to be comfortable with needle cricothyrotomies or chest decompressions. It's great to discuss with them and explain to them what's going on, but if they're not signed off on it and they're not comfortable with doing that skill, then you're ultimately responsible for patient care. So please step back and let them step back and watch you perform the skills at that point. Now, when a student walks into a site, they're not to just walk in the door and say, "Hi, I'm here to do clinical." They are supposed to contact a specific preceptor and have one person that essentially follows them through their shift and is ultimately responsible for their activities while they're there. There should be some kind of a tracking form, a sign-in, sign-out sheet that logs when the student was there and how much they did. When can a student be a student? Well, they cannot be part of the primary care team. The way that we describe this is if you were to take a little eraser and remove the student from that setting and get them out of there, do you have a viable crew? This applies a lot more to a field setting than it does to a hospital setting, because in a hospital setting you've got a large number of people that are potentially around. But in a field setting, if a lieutenant or a captain, albeit well-meaning, may authorize one of their employees to jump over onto the medic because they're going out on a chest pain, they go to the scene, they start an IV, they start doing some medications, and then a fire call comes in, they pull them back on the engine to go to the fire call. That's essentially a dangerous situation because the student wasn't acting in the role of a student at the time. They're pulled out of that situation before proper patient care has been transferred. If you can cut the student loose all the way throughout the duration of that run, that's the safe way to do so. We don't mind students getting paid and working as an employee while they're giving these, doing this patient care and doing their clinicals. If they can, great, more power to them. We encourage that. However, they do have to be in a student mode. Now, when they accomplish this, what we ask is if they're there for a partial shift or even for a single run, they still fill out the daily clinical activity log and log all the information that's there, get the preceptors to sign off on what was done. And it's possible for somebody, we've had situations in Dayton, for example, where we'd have an extra body. And rather than running a 5-man engine crew, we'll let that student do their clinical because we know it's an important need for them. They're a third person on a medic crew. They can continue doing those runs. If somebody calls off sick then, now we need them to come and backfill that engine crew, but we can let the student go to the hospital, finish out the run, and as soon as they're done, well, that medic needs to drop them off at company so-and-so so that they can fill in and jump on the engine. There's nothing wrong with that whatsoever. As long as the student goes out the door with the medic or arrives at the scene with the medic, they stay with the medic throughout the patient care, and they're there when the transfer is accomplished, there's no problems with doing that. And even for single and individual runs for that, there's no problems there. It's just if they're trying to do it for a partial thing. It's not an issue of whether they're volunteer or paid at the time. Faculty in the clinical setting are not allowed to precept. This gets a little strange. Anytime a student does an invasive skill, if a student's going to start an IV, you need to have a preceptor there that has proper scope of practice at the facility. I'm a paramedic, have been for 20 years, and I am not eligible to be a preceptor at a hospital setting. I'm not eligible to be a preceptor at an agency where I'm employed when I'm working on behalf of Sinclair. I'm essentially wearing a different shirt in this case, or kind of a different hat, if you will. When I'm there, my purpose is to evaluate and correct problems with the student. I can act as a liaison with the facility, but my purpose there is not to observe the student's patient care and assume responsibility for patient care. I don't have that right to do it, despite the fact that I am an experienced paramedic. That can become a little bit uncomfortable for some people. They think, well, wait a minute, you've got me as a nurse, I've got to go in the room with the patient and the student, even though there's a faculty member there, It is a difference from the nursing faculty. The nursing faculty that we have at Sinclair have a scope of practice. It's a slightly different animal, so just keep that in mind when you're in there. Likewise, if a student comes up to you and is asking for skills and you say, yeah, room 6 needs to have an IV started, there's the tray, go have at it. They're not to do that invasive skill without your presence. I don't have a big problem with you letting the student walk down the hall, put a tourniquet on, look for a site, and once they're getting ready to do the stick, they can call you back over and say, hey, come on over and take a look and see if everything that I'm doing is correct. But when a needle's poking through the skin somewhere, essentially the nurse or the paramedic or some other preceptor needs to be around at that time. All right, so what are some characteristics of a good preceptor? Well, first off, we have to talk about certification levels. In the hospital setting, the state requires that a preceptor be at least a paramedic in order to precept an EMS student. So essentially, in order to precept in the hospital setting, you need to be at least a paramedic. That includes a nurse, it includes a physician's assistant, and it certainly includes a physician. So for a respiratory tech, I've had some issues where maybe a respiratory tech will allow a student to go do a ventilation, or they're kind of supervising while they're doing that. Non-invasive skills, in the same vein that a student might be able to be supervised by a nurse, is probably okay in those settings, but we're looking for a paramedic level certification in the hospital. Out in the field, though, there's nothing wrong with an EMT student being precepted by an EMT. You don't have to have a paramedic available in order to precept an EMT student. Now, the facilities may choose to change that rule. They might say the only people we're going to allow to precept are paramedics. That's up to the facility, and there's nothing wrong with making that kind of a guideline if that's the standard. The recommendation is that they have a year of experience in care. We'd prefer somebody that just graduated from a program, not being the preceptor, a month after they got their card. Although we don't have a hard and fast requirement that they can't precept. It's up to the facility. If the facility wants to say they need to be a medic or need to be a nurse for 3 years in the facility, that's fine. Once again, follow your own personal policies on there. Some of the characteristics when you do this is work on communication skills with the student. We want the students to feel comfortable talking with patients, talking with staff, talking with family members, and getting the information that we need. Allow them some constructive feedback. Tell them what they did right. Tell them what they did wrong. Tell them how they can improve the skills for the next time that they encounter a patient. Recognize and address student anxiety. Sometimes you get a student that walks in there and they're shaking and really, really uncomfortable in that situation. Walk in and explain to them, hey, you get comfortable with this. And the idea is to just jump in the pool and get your feet wet. If you're not swimming, you're not going to learn how to swim. Granted, yeah, we'll put the waders on you, we'll put the little floaties and all that other stuff on you, make you comfortable, but essentially we want you to get in there and start getting hands-on and talking with patients. The first time you ask an 86-year-old patient about bowel habits or a younger patient about menstrual cycles, it's a little bit unsettling, especially for the guys. But after you've done it hundreds of times, it just becomes more second nature, so allow them to do that. The other thing is realize that the students aren't perfect. We realize you're not perfect. I'm certainly not perfect. The students aren't perfect either. It's okay to let them make some mistakes. I love having assessment things. We never put patient safety at risk, but I love having an assessment where a student will walk in and I'm kind of snickering they're in for difficulty breathing. And they go through, ask some questions, some history, and then they walk out and then they try to give me a report. Great. How are the lung sounds? I don't know. I didn't listen. Well, why don't you go back in there and take a listen and see what you think? So when they listen to the lung sounds, then now they've got that information. Come out and say, what were the allergies? I don't know. Why don't you go back in and ask them? And when you've asked them to go back into the same patient 4 times once, they usually get pretty good at remembering to ask those questions the next time. Whereas if you prompt them each time all the different questions that they need to ask, they don't really learn from that. So it's okay for them to make mistakes. Now, if they're getting ready to start an IV in a distal fashion where they're pointed down towards somebody's hand, or if they're getting ready to push a wrong medication, whoa, stop. Anything that risks patient safety needs to be stopped immediately. But minor mistakes, it's okay. It's okay to give them the chance to fail occasionally, as long as it's not a major patient care impact. Well, right on that same vein, we need to talk about patient confidentiality and affective domain. How do I interact with a patient? Am I walking in and introducing myself? Am I introducing myself with a smile? Am I showing concern for the patient? Am I appropriate in the way that I introduce myself, in the way that I interact with the patient? Am I coming across too overbearing? Am I coming across too timid? Am I pushing into areas that are inappropriate in whatever fashion that may be? Am I not respecting the patient's privacy? Am I all of a sudden starting to ask questions with family around, or am I standing in the hallway talking about a patient? And I have to catch myself with this. Sometimes we'll go in and we'll evaluate a patient, and then we'll come back out of the room and I'll want to answer some questions. I've learned, no, I need to go back to the EMS room. I need to go back to kind of a neutral area rather than standing out in the hallway where people are walking past and discussing a patient condition. So it's real easy to fall into that trap, but are they protecting the patient's privacy? If you're in a field setting, is the student walking up the sidewalk as opposed to right through the middle of the lawn? If they're walking in with muddy shoes, do they wipe their feet? If we have to move furniture, are we being gentle with how we move the furniture? Are we just kind of kicking stuff out of the way? I'll argue, yes, in a cardiac arrest situation or serious things, we might be a little bit more brusque in how we accomplish skills, but a simple matter of kicking a table over on its side and lifting it up and shifting it over just a little bit, it's real easy to take the time to do that, and it makes a big difference. If a patient's in a non-critical situation and they have an issue with their dog or their cat, can we get a hold of a family member who's going to come by and take care of it? I know that doesn't seem critical in the short term, but honestly, it can tend to buy some credibility with that patient over the long run and will allow them to feel more relaxed with the paramedic in the future. So there's a good quote out there: people don't care how much you know until they know how much you care. If you demonstrate, I have no respect for you or anything about you, how can they respect what you know? How do they expect you to treat the patient best? I've dealt with complaints for a number of years, and I get compliments from patients when the paramedic might have done something a little bit wrong as far as the care and treatment goes, but because they were very, very nice when they were there. I've likewise had situations where the paramedic clearly saved the person's life and made a huge difference in the patient outcome, and yet they tracked mud on the carpet and they were mean, they kicked the dog, they yelled at the dog or something, and they just were disrespectful in the way they treated the patient, and I get a complaint over that. So the way that you come across to a patient is critical, and the way that they interact with you as staff members and with colleagues is very important. If there's any major problems, kick them out of the clinical setting, let us know so that we can address the problem and get them fixed. A lot of these students are fixable. It's just that if we don't know there's a problem, we don't know there's a problem and we can't fix it. When the faculty are in the site with the student, we see that, but sometimes they might act a little differently with a faculty member present than they will with just another preceptor, let alone if they're in a room with a patient by themselves. So make sure that you contact us and let us know of any problems, and minor corrections, just talk with the student and give them some suggestions. A little bit of career advice on there can go a long way. In the unlikely event that a student has an exposure or an injury of some sort, we ask that they stop doing clinical as soon as it's safe to do so. If you're right in the middle of something at a scene, you may need to finish the transport. Again, triage sort of comes into play. If the student is more injured than the patient was initially, they may become the higher priority patient. Certainly some levels of triage dictate that emergency care providers that are injured at a site get transferred up to a red tag just because they're a big distraction. However, if there is something that's going on, follow the policies that are listed in the Preceptor manual, in the Preceptor Training manual, so that we can make sure that the information's in there. We ask that the students contact their educational institution within 2 hours, 4 hours really at the outset. So ultimately, if that's 2 or 3 o'clock on a Sunday morning, The phone will take a message. You're not going to catch one of them there. If you've dealt with me in the past, you know I'm a night owl and I might be up at 2 o'clock on Sunday morning. I can pretty well guarantee you that most of the program coordinators will not. But a message being there when they arrive on Monday morning, they can double check on that and follow up. So making sure that that's initial contact has taken place can help us make sure all the paperwork gets covered properly. We have about a 72-hour window to get things in, so we want to try and minimize that as much as possible. On a weekend, that goes away very quickly. There is a form, and the forms are available in the back of the Preceptor Manual. You're welcome to glance through it. Students should have a copy in their clinical books that they carry with them at all clinical orientations or at all clinical activities, so that you can fill that out. Please make sure that gets taken care of and gets submitted appropriately on there. Generally speaking, for exposures and for injuries, they just have the right to get their care. Students typically have some level of limited accident and malpractice insurance as a part of their program, and it's a part of the agreement that we have with the EMS agencies that we will provide some level of protection from them. It doesn't cover everything, and things have to be done in the proper format in order to get coverage. But there is some levels of process. Please refer to the Preceptor Training manuals as far as process, and make sure that the student is thinking about that and looks back at their sheet. They don't run into that very often. Many students go through without a single problem. So if they do run into that, make sure that they know what they're looking at. Okay, I need to run through the two segments here real quick on what are the expectations of an EMT student and what are the expectations of a paramedic student. I'm going to use my handy dandy list here to make sure I don't hit the wrong things on there. For an EMT student, the students are young and inexperienced. Don't expect the world from them. They do know how to do a basic patient assessment. This might be their first time in a clinical setting. If it's their second or third, they might have very limited experience. Others might have been dealing with patients all their lives. So, you know, there's different levels of comfort. It's kind of fun when we do pediatrics. We'll have some paramedics, their moms or dads, they've got nephews, little brothers and sisters, nieces, and they've dealt with kids all their life and they're very comfortable. We'll pick up the kid, they can toss them around, joke, and we'll get some of the biggest, strongest medics that are out there. I ain't touching that kid with a 10-foot pole. I'm really uncomfortable. So it's kind of fun to watch that, but push them a little bit out of their comfort zone as long as patient safety is maintained throughout there. Don't feel uncomfortable with giving them a little bit of a boost and putting them in the right direction on there. Orient them to some of the job expectations, orient them to the equipment. A paramedic, generally speaking, understands what NIBP, non-invasive blood pressure, is going to be on there on the monitors. An EMT might not have any interest in trying to touch a monitor that exists there. So kind of show them what they need to do, show them what not to be touching or playing with. Don't unplug this to plug something else in and end up pulling somebody off of a vent needlessly or so forth. Let them observe the patient care. It's okay for them to see what you're doing. They're not really doing a whole lot of invasive skills. They shouldn't really be giving medications on there. If they get the opportunity to do CPR, by all means, get them in and on the chest. They really need to get that experience. Bagging somebody, once the seal is kind of established, monitor them very closely and make sure they're getting a good seal, they're getting in chest rise and fall, and kind of encourage them and coach them through there. Again, you're a teacher and a mentor and a coach and also responsible for patient care, so you're putting on many hats when you do this. And they should not be placed in any real decision-making roles. So refer to your preceptor manual if you've got other questions as far as EMTs. Now on the paramedic end, they're expected to actively participate in some of the patient care and in some of the assessment techniques. They can do a much more detailed assessment. They've had that pretty well beaten into them as far as assessment goes. They may not be comfortable with megacodes at this point, so be aware of what their training level is based on their skill levels. They should be able to demonstrate competency in the assessments, though, in an IV access and in how to push the medications, even though they may not be perfect as far as what everything does. Again, refer to the Preceptor Training Guide for additional things. We want to push them into critical thinking skills, though, to an extent. We want them to say, I might have this condition, that condition, that condition, or that condition, and you can watch the wheels turning. I like to use the TV series House as an example of this. They had, Simpsons did a parody of this that I thought was great. they're on their fourth wrong diagnosis before they come up with the right diagnosis at the end of the show. And we want them to think that way. Hey, could this be stroke, seizure, or syncope? How do I rule something in? How do I rule something out? Ask them those questions. See that they're asking themselves those questions. That's what's going to make a great paramedic. And that's really one of the biggest differences that are in there. The skills difference between an EMT and a paramedic is fairly limited. I am going to argue, yes, there are differences, and certainly an IV is going to take a while for somebody to get comfortable with doing so, but I can teach an EMT how to do an IV fairly quickly. I can teach them several meds, and I can probably teach them ACLS megacodes fairly quickly, but if they don't know critical thinking skills, they don't know when not to use this particular drug. When does atropine not work? When does epinephrine not work? When is cardizem a better choice than amiodarone, or vice versa, or adenosine? It's the skills level. We want them doing that extra level of critical thinking. Okay, we're almost there, folks, but I would like to take just a few minutes to talk about documentation. The documentation forms are in your Preceptor Training Manual, and the students are responsible for bringing these to the sites. You don't need to keep a stash or a stock on them. If you have a few, great, but it's not your responsibility to stock those forms for them. But there's several different forms that are involved. First off, we have the insurance forms that I've already talked about. Make sure that a student fills that out as long as they're capable of doing so. We also have assessment forms. Each time a student does an assessment on a patient, we'd like them to document that form. Now, when a patient is assessed and the student does a full documentation, it's really nice if we can have the preceptor just glance over that, because the preceptor is likely familiar with that patient to an extent, whereas if they bring it back to me, I don't really know what happened to that patient, and I can give some guidelines of, hey, this is I can figure out what's going on here but not figure out what's going on here. But it's really nice if you've got that preceptor's input right at the site that can say, this is where the problems were and this is what we tried to accomplish. So with that, you don't have to do a grand detail 45-minute diagnosis of their documentation skills. Our faculty will do that, but just glance over there and see if there's little tips or tricks that you can do. And we ask that you sign those document forms, and that's a one-for-one basis. In the old days, we used to have documentation booklets that had multiple signatures, and the average paramedic student would have 300 or 400 signatures throughout that time. We've, quite a while ago, since simplified that down to a single paramedic student daily clinical activity log, and there's an EMT student daily clinical activity log. There's several different areas that are completed. I'm going to discuss the paramedic one because it covers all of the basic areas here as well. But looking at that form, these forms are two-part forms that are available, and once again, they're listed in the paramedic preceptor training manual, so you're welcome to look at those forms and you'll get quite familiar with them. They're asking for the student's name and the start time, the end time. They're supposed to sign in and sign out at your facility. In addition to this, there should be some kind of an activity log of when the students arrived and left, and that way your facility can track who was there above and beyond these forms. We have at the top 4 different leadership evaluation areas. There's appearance and preparedness, coordination and flexibility of treatment, attitude and affect, communication and documentation. And those are simply satisfactory or needs improvement, and the descriptions are listed on there as well. The next area on here are the skills, such as IVs, intubations, patient assessments, and so forth. Under the skill aspects, you've got IV established, the different injections that were done, if a student had ventilated a patient, if they performed CPR, and so forth. You have the ability to mark those areas. It's just a simple number that's been completed, and they've got needs improvement, satisfactory. On this one, we added an outstanding. If they're really on their game and they're doing an excellent job of patient care, it's fine to go ahead and mark that off. On patient assessments, you have the different age categories. They obviously only get one age category for an assessment. The following area that's in the next column there for the paramedics is patient's primary presenting problem. They only get one per patient. You might have somebody that had abdominal pain, difficulty breathing, and chest pain, but they have to decide which is the primary reason the patient came in. If they had difficulty breathing, which is causing them some pain in their chest when they take a deep breath, it's probably respiratory in origin. If, on the other hand, they had a patient that had a cardiac event that's a bit short of breath, it's probably a chest pain origin on there. Trauma on this does not need to be a trauma alert type trauma. You don't have to have somebody that needs 2 large bore IVs and so forth. Somebody that twisted their ankle can be classified as a trauma assessment on this. I realize it's not the most detailed of trauma, but it is exposing them to different types of injuries. The assessment that you do on a traumatic injury is different than that kind of an assessment that you would do on somebody with a medical problem such as abdominal pain. It's what we've taught a lot of times is called the 80-20 rule. On a medical patient, 80% is what the patient tells you and 20% is what you actually observe. Whereas on a trauma patient, 80% is what you observe and 20% is what the patient tells you. So, and yes, those are rough guidelines, but they give you a bit of the feeling. And we're just asking that they observe different trauma patients. There's quite a few that we ask for. So the full-blown trauma alerts where they've got multiple surgeons in and working on the patient, going up to the OR, is not necessary to qualify as a trauma in that respect. The next area that we have is the ambulance experience area. So for the hospitals, they have ambulance runs, they have ALS level runs, and they have leadership runs. Now, ambulance runs is any time the ambulance runs out the door, drives down the street, goes and assesses a patient and transport the patients to the hospital. That qualifies as an ambulance run. For an ALS run, it has to be somebody that requires ALS level skill. That's not somebody who twisted their ankle and we decide we're going to start an IV just so that we can turn this into an ALS run. But if there's a need or a desire to give pain medication to the patient, if you're going to ask the question or if you're going to give pain medications, then that's fine. If you're not even thinking about giving pain medications, then that doesn't qualify it as an ALS run. I'm going to go one step further here. If we go out on a diabetic that's unresponsive, roll up on the scene, and the patient is out, we establish an IV, push D50, the patient wakes up, talk to the patient, they're there, they have family members that are there, they're aware of the situation, they took their insulin, didn't eat, and they're ready to eat a meal, and they want to refuse care, I'm going to argue that that's an ALS run. Likewise, what if we had a cardiac arrest? That's like the absolute grand poobah of all the ALS level runs, and in many cases that's not a transport. So a necessity of transporting the patient to the hospital is not the mandatory aspect. But if we walk up on a scene and it's an auto accident and somebody decides that they're going to refuse care, that probably doesn't qualify as an ambulance run, let alone as an ALS level run. So ALS level runs, though, that require that ALS level care are an ALS run, and they also count as one of the ambulance runs. Hence, you need more ambulance runs than you do ALS runs. When you get your 30 ALS runs, those 30 count as 30 of the 50 ambulance runs that we need for Sinclair. Other programs may have slightly different numbers, but they're going to be roughly similar. Leadership runs are the top category, and those are typically done by students that are at the end of their program. They're just about wrapping up for the process, and we want them to take a leadership role. When they arrive on the scene, they're basically acting like the primary paramedic on the scene. They initiate the assessment, they do all the key points of the assessment, they discuss the treatment options with the patient, they establish care. They don't have to do everything. If somebody else starts the IV, that doesn't take it away from being an ALS run or a leadership run. If they're dictating the care, that's fine. Now, if they just stand in the back and do nothing and say, I want you to do an assessment, I want you to take blood pressure, and I want you to do an IV, and you to push a medication, and never touch the patient or do anything like that, that doesn't qualify. But if they're an integral part of the team and they're acting in a leadership role and you're just splitting the tasks, there's nothing wrong with that. A leadership run, by our guidelines, must be an ALS run. You can't do that on a basic level run. Yes, they can lead a call on a basic run and it's good experience for them, but it doesn't count as a leadership run unless it's ALS level in care. So if I get a leadership run, I have a leadership run, I also have an ALS run by definition, and I have a patient care or an ambulance run. Along with that, if it's an adult with chest pain, I have an adult assessment, I have a chest pain assessment, I did a patient care documentation. On the patient, I started an IV, I gave a medication through the IV, and let's say I had to give a sub-Q medication as well, and I gave a nebulized medication. I'm up to the point now where I have 10 different skill points for one single incident. There's nothing wrong with that as long as it's not multiples within a locked category, such as patient primary presenting problem or the age-based assessments. You can't assess one patient and have it be an adult and a geriatric, obviously. And the fact that you assess them, reassess them later on after giving a med doesn't count as a second assessment. It's one per patient encounter in those aspects. If you have any questions on that particular form, again, refer to the manual and talk to your EMS program, and feel free to give any questions that you need. You can email them or contact the EMS department at your agency for those questions. Last thing I'd like to touch on with documentation is that dreaded yellow copy. What happens to that? Does it go in the trash? No, and hint, that'll be one of your test questions. The yellow copies on the forms are designed to go through the EMS coordinator at whatever the agency is. That might be the EMS coordinator at a hospital, it might be the EMS coordinator for a fire department or other field experience facility. Wherever those sheets go should go to that EMS coordinator, and we'll provide you envelopes that you can mail them back to the EMS department at the college the student was attending. Please do that, because what we try to do is sometimes we get feedback from the preceptors and from the facilities as well out of those forms, and it also gives us a secondary tracking mechanism. The white copies of the forms stay with the students at all times. Okay, thank you folks. I really appreciate all the time that you've taken listening to me sit here and babble on for quite a while, but I hope this was informative and at least somewhat entertaining for you. The purpose on this, again, is to help us maintain our national accreditation and make sure you understand what's necessary to properly precept a student for one of our educational institutions. You are the backbone and the pulse of the EMS community. We thank you again for all the time that you've spent doing that. Please stay safe. In order to complete this process, I will ask now that you take the online quiz, about 10 to 15 questions. Make sure that you mark all the agencies that you specifically work for or have a direct employer-employee relationship, whether it's volunteer or paid, and submit that quiz. If you would like the hour of continuing ed, follow the additional link and use the and complete the course evaluation survey, which allows us to generate your certificate. That asks for your name, and in that case we ask for an email address so that we can get in touch with you and email you your certificate. The certificates sometimes take a little while to get to you. If you need it in a rush in order to finish your requirements for accreditation or for recertification, just contact your program agency and they'll arrange to expedite that process for you. Thanks again for all your help. Please stay safe, and God bless.